Sir.
Good afternoon, Ramasubramaniam.
Sir, good afternoon, sir. Good afternoon. Yes.
Nice meeting you and your team.
Yes, sir.
Yes,
sir.
Shall we start?
Yes, sir.
May I request all of you, please get muted. Please mute yourself. Somebody has not muted yet. Okay. A warm welcome to all the participants for yet another edition of this monthly discussion of nephrology clinical discussion. And we have designed this discussion in such a format that the predominant component of it is a long case scenario discussion, almost in the form of examination, clinical examination pattern. Then few snippets, one, a historical pearl, then biostatistics, and a histopathological discussion, histopathological case scenario discussion. So to start with, we'll go ahead with the long case presentation. A warm welcome to the postgraduates of Tirunelveli Medical College. A word of appreciation for them. I witnessed how sincere and how knowledgeable they are in the recently conducted NATPO meet at Kodaikanal. I was really amazed the way the postgraduates of Tirunelveli have worked up cases and so on. So let's hope that today's discussion will be really fruitful and useful for everyone. One request to the presenter is that your presentation has to be comprehensive, no doubt, but it has to be precise. No repetition of information, and you should filter out information which are provided to you, but of no clinical significance to the current issue of discussion, so that you should be able to complete your presentation by 10 to 12 minutes. That is what most of the examiners expect, so that the examiners should be given adequate time for a detailed discussion. Sometimes what happens is that you may over enthusiastically would like to provide the finest of details, and then that process you may consume more time in presenting. Some examiners think that it is a kind of a scheme or a design, a clever design to buy more time in presenting, so that the discussion is minimized. Why I'm saying is that some examiners, they visibly get irritated and they pass a negative comment. So what will happen is that once you receive that negative comment, that may set in a kind of a negative cycle, with negative vicious cycle. So that should not happen. So always practice. Of course, today it is not an exam. Just be relaxed, enjoy your presentation. But this is a general piece of advice. You practice in such a way that you kind of mentally prepare a format of history taking and presenting. Present it in a very cohesive, precise, but comprehensive way. Please go ahead. And at the end of the clinical presentation of the history, you'll be asked to provide the diagnosis or differential diagnosis, or if it is a long drawn history, the problem listing at the end of the presentation. Then you'll be asked to come out with the positive finding or the clinical examination findings. Then second time after the clinical examination, again you will be asked to come up with your diagnosis or differential diagnosis. That is the usual format. Sometimes there can be some deviation in formats. And in the clinical examination, please just go ahead in the very systematic way as you do in your MD exam as well. Some of the examiners may even reach up to the patient and then confirm the findings, certain findings, for instance, a bruit and all that. But most of the examiners, they may simply ask you to come up with only positive findings, not a systematic presentation. So mentally, you should be prepared for both these formats. don't get flabbergasted. Be ready for both these. Okay.
Okay.
Fine. Please go ahead. Introduce yourself and go ahead.
Sir, my name is, good afternoon, sir. Thank you for giving this opportunity for presenting a case. My name is Dr. Harikrishnan and I'm a final year resident in Tirunelveli Medical College.
Yes.
So is my voice audible, sir?
Yeah, quite audible.
So my patient is Mr. Balakrishnan, 35-year-old male hailing from Alangulam, who has studied till 10th standard, who now owns a grocery store, now presented with complaints. Actually, he was admitted in view of rising creatinine on a routine follow-up in the month of April 2022. History of presenting complaint. My patient, he gives a history of kidney disease or renal disease, and now he's a case post-transplantation, now currently under follow-up from the Department of Nephrology, Tirunelveli Medical College. Hence, I would like to start the history from the beginning of his initial symptoms. Patient was apparently normal till around 7 years back, when at the age of 28, he developed complaints of dyspnea on exertion, which was insidious in onset, gradually progressive, and initially with only severe exertion, which gradually progressed over a period of 2 months to dyspnea even on mild exertion. However, at that particular point of time, he had no complaints of orthopnea, PND or resting dyspnea, no associated chest pain, cough with expectoration or hemoptysis, no history of any facial puffiness, pedal edema or abdominal distension. However, it was associated with increased tiredness and easy fatigability. Hence, he consulted a nearby local hospital and some blood tests were done. And he was also informed to have some kidney problem and advised further evaluation. The values of investigations he actually doesn't remember. He was given some symptomatic treatment for a few days and thereafter he actually lost follow-up. He did not go for further evaluation and he continued his routine work even though he remained symptomatic. 3 months later, he noticed onset of bilateral lower limb edema, insidious in onset, gradually progressing from the ankles to just below the knee over a period of 1 month. No associated facial puffiness or abdominal distension, no complaints of frothing of urine, hematuria or oliguria, no chest pain, orthopnea or paroxysmal nocturnal dyspnea, no associated distension of the abdomen or yellowish discoloration of urine or eyes noted, no history of any arthralgia, skin rashes, oral ulcerations or photosensitivity. He was then shown to a local hospital where the doctors informed him to have high blood pressures around 190 millimeters of mercury, and certain blood and urine investigations along with scans of abdomen were also done. And he was informed to have a creatinine around 2 and then referred to a nephrologist, where the need for a kidney biopsy was informed and hence he underwent a kidney biopsy which was uneventful. Following the biopsy result, he was informed that his kidneys had irreversible damage and he would require lifelong treatment and follow-up. And because he had hypertension, some antihypertensive medications were started. However, no costly injections or special dialysis was given at this particular point of time. And over the period of next 2 years, he had regular follow-up and continued the antihypertensive medications. No history of any other medicine use. He became symptomatically better. BP came under control. No history of any emergency hospital admissions with dyspneic episode, nausea, vomiting, or altered sensorium. But he says that his creatinine rose gradually. No history of any blood transfusions or onset of any new symptoms related. And he had urine output of around 1 to 1.5 liters per day. And he had no complaints of hematuria or proteinuria. 2 years later, that is at the age of 32, while he was on a routine follow-up, the doctors informed him to have a creatinine of 21, even though he was asymptomatic, and was initiated on elective hemodialysis via left femoral catheter, followed by the creation of a left forearm fistula within 2 weeks. He continued his maintenance hemodialysis thrice per week for the next 7 months. And during this particular time period, he was also worked up for a transplant workup with his mother as a potential donor, aged 50 years with the same blood group and with no prior comorbidities. And during the period of his dialysis vintage of 7 months, he did not give any history of blood transfusion, no history of any emergency hospital admissions, no history of any access related issues or complication, no history of any fever with chills episode, and no history of any fluid overload state, no history. And he also completed 4 doses of his hepatitis B vaccination, and he also received injections for anemia thrice per week. And he also gives no complaints of any abdominal distension or yellowish discoloration of eyes or sclera during his dialysis time. His urine output, however, from a state of 1 liter per day came back to around 10 to 50 ml per day. and after completing all the workup, he was admitted in January 2020 and for renal transplant surgery. He remembers that his blood tests were done for both the patient as well as the mother, and the doctors informed that they could proceed with the surgery. And hemodialysis was done prior to the surgery. However, he doesn't remember any injections being done prior to the transplant surgery or on the day of surgery. And he underwent a ABO compatible living related renal transplant surgery with the mother as donor. Post surgery, the post-operative period was uneventful, with no history of any prolonged ventilator support or blood transfusions in the immediate post-operative period. He passed around 2 liters of urine in the first 2 days, which gradually increased up to 6 liters per day over the next 1 week. And he remembers that the creatinine, which was initially around 5 to 6, it fell over to a value of 1.6 over the period of 2 weeks time. However, he did not require any hemodialysis support. And both the urine bladder catheter and the drain tube was removed during the second week. He remembers that he was given tablets named tacrolimus, mycophenolate mofetil, and prednisolone, with the levels checked frequently. However, he doesn't remember any values. 2 weeks after the kidney transplant, he noted that multiple fluid-filled skin vesicular lesions all over the body, which was associated with fever and myalgia. However, the particular skin lesion subsided after a period of 1 week treatment with some medication, and he remembers that at this particular point of time, the dose of tacrolimus was reduced. 1 week later, he also developed high-grade fever with chills and associated breathlessness, and it was associated with cough and scanty white expectoration. However, there was no decrease in urine output or abdominal pain or frothing of urine or hematuria. He was given some IV medications for 1 week, after which he symptomatically became better. And after a period of 3.5 weeks after the transplantation, he was discharged with a nadir creatinine of 0.9 at the time of discharge, with a urine output of 4 to 5 liters per day, with the tacrolimus being advised to take on 1 milligram 3 tablets in the morning and 3 in the evening, and of 500 milligram 1 in the morning and 1 in the evening with prednisolone. And he was asked to come on every week for follow-up. In the month of early March 2020, he was admitted for the stent removal, and at that particular point of time, the RFT as well as was normal, and he was passing around 4 to 5 liters per day. In the month late of March 2020, he had creatinine of 1.8 with a normal blood pressure recording. However, he was asymptomatic. No oliguria or frothing of urine or hematuria was noted. No abdominal pain complaint. However, he was admitted and a graft biopsy was done simultaneously. Levels of tacrolimus were also sent. However, after this biopsy report came, the tacro dose was actually reduced. However, he doesn't remember any other treatment history. In the month of April 2020, that is 1 month after this episode, on a routine follow-up, he was found to have a creatinine value of 2.6. However, he still remained asymptomatic, and a second graft biopsy was done. He remembers that he was given initial IV injections over a period of 3 days, followed by the use of alternate day special forms of dialysis, 6 sessions, and injections post each session of dialysis. And hence the tacro, he also remembers that his tacrolimus was changed to cyclosporin. And after a period of 2 weeks of IP care and treatment, his creatinine from 2.6, it came down to 1.5 and hence discharged. In the month of May, that is 1 month after this episode, he had an episode of fever with loose stools, which settled spontaneously. No change in the maintenance immunosuppression was attempted, and he was totally asymptomatic. 1 month later, in the month of June 2020, he was detected to have high blood pressure recordings on a routine follow-up, and he also was found to have a creatinine value of 3.3. However, he still remained asymptomatic. However, renal biopsy was done, and following biopsy, the medication was changed from cyclosporin to tacrolimus, and he was also started on antihypertensive medication. BP was controlled and creatinine came back to normal values around 1.2, and he was discharged after 1 week. In the month of August, when he came for a routine follow-up, he complained of gradual painless loss of blurring of vision in both the eyes, which gradually progressed over time with associated photophobia. No associated eye pain, tenderness or increased lacrimation or even reddish discoloration of the eyes were noted. No associated headache, seizures or fever episode, and no complaints of any floaters in the eye. Opthal evaluation was done, and he was informed to have bilateral eye cataract and also some changes in the retina. And in December 2020, he underwent a left eye cataract surgery. And in January 2021, he was again admitted with complaints of increased tiredness, dizziness, and loss of weight, with associated heartburn, nausea, and increased thirst. However, there was no complaints of any abdominal pain or tenderness, loose stools or oral ulceration, no complaints of yellowish discoloration of the eyes or urine, no fever, no dysuria, no complaints of frothing of urine or oliguria, no dyspnea or bleeding manifestation. And he was detected to have high blood sugars, which actually required insulin to be given for 2 days along with IV fluids. And he was discharged with a creatinine value of 1.2 and with insulin and oral anti-hyperglycemic medications. And for the next 6 months, he remained asymptomatic with creatinine levels frequently varying between 1.2 and 1.4. He had good appetite and weight gain. And also the tacro levels were checked frequently, which he says that it is in the normal range. In July 2021, he also underwent a right eye cataract surgery. And 3 months later, that is in the month of November, he again approached us with complaints of not improving vision post-surgery. And he underwent an ophthalmic review, post which he underwent laser treatment in both the eyes. And at that particular point of time, his admission showed a blood pressure reading of 150 millimeters of mercury with a normal output of around 3.5 liters and an RFT value, which actually he doesn't remember. And from January 2022 to March 2022, he also subsequently received 3 injections in both the eyes from the Department of Ophthalmology. And he remained asymptomatic post injections. Now, in the month of April 2022, when he came for a routine checkup, he was found to have elevated creatinine values. Hence, he was admitted for evaluation. No complaints in the form of dysuria, oliguria, hematuria, or frothing of urine. No abdominal pain or graft site tenderness or abdominal distension. No leg edema or facial puffiness. No complaints of any fever with nausea, vomiting, loose stools, or yellowish discoloration of eyes. No history of any drug default or native medicine use. No history of headache, seizures, and altered sensorium. And at the time of admission, he had a urine output of around 3.5 liters per day. Coming to the past history, he has actually born out of a non-consanguineous marriage and born by normal vaginal delivery with an uneventful perinatal period and childhood history. No urinary stream abnormalities noted and no history of any recurrent urinary tract infections in the childhood, and no childhood history of any hematuria, oliguria, or frothing of urine. And he doesn't give any history of use of any native medication, and no history of any diabetes mellitus, hypertension, coronary artery disease, or pulmonary tuberculosis prior to this till now. Personal history, sleep and appetite is normal, bowel and bladder habits are normal, and no history of any addictions. Family history, he is survived by his elder sister, and his father is actually no more. He says that he died due to a coronary artery event, and he survived his wife 34 years and 2 sons, which is 14 and 12 years of age. No history of any significant renal disease in the family, no history of hypertension or diabetes also. Currently, the donor is healthy with the recent values of renal function in the normal range.
Fine. Have you finished?
Yes, sir.
Yeah. Can you just summarize the history?
So my patient is a 35-year-old male who was apparently normal till 7 years back, till the age of 28 years, when he initially presented with breathlessness, bilateral leg edema, and hypertension, diagnosed to have renal failure, underwent renal biopsy, became dialysis dependent within 2 years of follow-up with a dialysis vintage of 7 months, underwent ABO compatible living renal related transplant with the mother as the donor, with a history of probable slow graft function, and post kidney transplant having history of infection with multiple skin vesicle formation and lower respiratory tract infection, discharged after around 3.5 months with a nadir creatinine of 0.9 with no history of any prolonged complications, that is post-operative complications, and on a regimen with tacrolimus, MMF, and prednisolone, with history of graft dysfunction 2 months post kidney transplant, whereby tacro dose reduction was made after a renal biopsy, first renal biopsy, again readmitted with graft dysfunction, the second biopsy done, and special form of dialysis in the form of probable plasma exchange given, and dose being changed from tacro to cyclosporin, again readmitted within 2 months within graft dysfunction, third biopsy done with the drug change from cyclosporin back to tacrolimus, and diagnosed with bilateral eye cataract, underwent surgery later with the diagnosed post-transplant diabetes mellitus around 9 months after transplant, now undergoing treatment with insulin and oral anti-hyperglycemic drug, now underwent recent laser surgery and also intraocular injections in the month of January to March 2022, now again admitted with acute graft dysfunction.
Okay, fine. So one important history I would be interested is with regard to COVID.
Yes, sir.
Whether did he suffered a COVID episode, because the most of this clinical history has happened during the COVID era.
COVID time. Yes, sir.
Yeah, COVID time.
He was not infected with COVID, sir.
No, that history is very, very important.
Okay, sir.
And his vaccination status, how many doses he received.
Okay,
and so that piece of information is very vital.
Okay, sir.
Please don't forget, because normally it doesn't occur to us, because we are used to taking history and presenting in the usual format. But never ever forget COVID, because COVID in multivarious ways can afflict a transplant recipient. In terms, it can cause just pneumonia, it can cause graft dysfunction, it can cause graft thrombosis, whatnot. It can induce diabetes, is it not? Yeah, there are so many things that's important. So, have you gathered information regarding COVID?
Actually, he has not been infected with COVID and he has not taken vaccinations for COVID also, sir.
Not vaccinated at all?
Not vaccinated for COVID, sir.
So, even that information is important. It's a very vital information, because he remains vulnerable. Is it? Yeah.
Okay,
fine. Now, can I ask you to list out the problems? Because, here it is not a single diagnosis. Suppose if you are asked to provide a diagnosis, how do you say?
ABO compatible, living, related renal transplant recipient with mother as a donor, with a history of probable slow graft function and probable post-transplant, immediate post-transplant varicella infection with lower respiratory tract infection.
No, that is problem listing. That is problem listing. So in these situations, only problem listing is expected. That will be appropriate. In case if you are asked to provide a diagnosis, you simply say that you started in the right way. ABO compatible, living related donor, renal transplant recipient. With multiple episodes of graft dysfunction and infection episodes. Currently, he's under evaluation for graft dysfunction.
Graft dysfunction.
So that will be the diagnosis, but problem listing is more important. Fine. You have listed the problems already. So let us come to each one of that quickly. I would like to ask you, what is the most likely etiology for his chronic kidney disease?
Sir, actually, he was diagnosed to have renal failure at the age of 28 years. And he was subjected to a renal biopsy at the initial presentation.
No. When you are asked this question, you just come out with the possibility. When you are asked to explain, then you can explain.
Okay. So probably the native kidney disease could be a chronic glomerulonephritis, and the probable differentials would be IgA nephropathy in the first instance and FSGS in the second instance, sir.
Okay. That's fine. Fair enough. Anything else? Can it be C3GN?
Yes, sir. C3GN also is a possibility, sir.
Why do you think it is CGN?
Because he was actually submitted to a renal biopsy at the time of initial presentation, sir. And he also presented with complaints of bilateral leg edema and complaints of hypertension. So this usually points to more in favor of a chronic glomerulonephritis, sir.
Quite true. So edema and hypertension more towards this thing. Of course, the tubulointerstitial disease, edema and hypertension are not prominent.
Okay.
But there are exceptions. What are the tubulointerstitial diseases which present predominantly with hypertension?
One tubulointerstitial disease which can present as reflex nephropathy can present with hypertension, and ADPKD also can present with hypertension.
Exactly. Fine. So what do you think about the virulence of the disease? Whatever be beta IgA, beta FSGS. According to you, within 2 years of diagnosis of the issue, he has gone into ESRD status.
Okay, sir. So
What comment on this?
it's a kind of a rapid progression, sir. Normally, if you consider IgA, it is not consistent with the natural course of IgA, sir. And also with the FSCS also, we don't expect a rapid progression like this, but there are possibilities that you can have rapid progression, in which we call it as malignant IgA. If it happens within
No.
a period of
No. I take your point. I mean, you just simply say that it is very rapid progression. That is all.
Okay.
Because the natural history of IgA nephropathy, nobody knows.
Okay. Sir.
But you can't say that it is not in conformity with the natural history of IgA nephropathy, because IgA nephropathy's natural history is quite varied. For instance, whatever we read in the textbooks, it is a natural history of IgA nephropathy of the Western Hemisphere. Whereas uniformly, in Indian experience, published Indian experience of IgA nephropathy, most of the patients, even at presentation itself, they present with fairly advanced disease.
Okay.
And they, in no time, they go in for ESRD status. Probably it is a biased observation, because we have the data of IgA nephropathy who are referred to tertiary centers.
Okay.
So based on that information, any number of publications have come up from different parts of India, particularly South India, including MMC. It runs a virulent course, at least in a major subset of the patients.
Okay.
So that's it. But which form of FSGS is known to have a very rapid progression?
Collapsing form of FSGS, sir. The history.
Very good. Collapsing form. Okay. If it is IgA nephropathy, what is the importance of this rapidity of decline of the kidney function and reaching ESRD status? Does it have any other implication?
The progress or the initial native kidney progression can be reflected in the post-transplant state. The disease, if it actually progresses a rapid course, it can actually recur in the same pattern in the post-transplant state also.
No. Rapid progression is one of the known risk factors for recurrence of the disease post-transplant.
Oh.
You are right. It is one of the risk factors. There are certain other risk factors. What are the other risk factors for recurrence in nephropathy?
Sir, one we have already sir, poor prognostic factors. Sir.
Not poor prognostic.
Doing a cadaveric transplantation.
The risk factors.
Living related donor, sir.
Recurrence.
Living related donor.
Living related donor.
Then
rapid.
Younger patients with a rapid clinical course in the initial part. Then IgA deposits at the time of engraftment in the graft kidney, sir.
Then one more, the most important one. A previous graft loss.
Previous graft loss.
Due to recurrence of IgA nephropathy.
IgA nephropathy. Okay.
So that is it.
Okay.
A little bit of deviation from here. So what I would do at this point of time is that I'll ask you to come up with the positive findings in the clinical examination, then we'll continue the discussion.
Okay. So on general examination, he is afebrile, conscious and oriented with no resting dyspnea. Height is 165 with a weight of 63 and a BMI of 23.
Only positive findings. Only positive.
On the blood pressure is 150/80 in the right upper arm. Head to foot, eyes, bilateral pseudophakia is present, and fundus shows bilateral laser, post-laser status. Oral cavity, there is no oral thrush, no gingival hyperplasia, and hygiene is good. No buffalo hump or moon facies, no hirsutism or alopecia. But the skin at the level of axilla and abdomen, it shows skin striae, and scars of previous healed vesicles have been noted in the trunk. And abdomen shows a J-shaped scar in the right iliac fossa. And left radiocephalic fistula is still functioning with thrill. No upper limb tremors or hyperpigmentation noted in the skin. No, and on abdomen examination, normal bowel sounds are heard and no renal bruising, and no renal angle tenderness or graft tenderness noted, and transplant kidney is palpable, sir. Apart from that, all the other systems are normal.
What is the blood pressure?
150/80, sir, in both the limbs, sir.
Both the limbs.
But
you said the AV fistula is still functioning on one side.
Left side or right side, sir.
But you prefer to check BP in that side also.
No, sir. Right side, sir. Only right side, sir.
Okay, that's right. Fine. So what will be the points you would look up in the neurological examination in a kidney transplant recipient?
Suppose
1 second, 1 second, just 1 second. Examination. Neurological
sir.
examination in a kidney
Sir.
transplant recipient. That's what I wanted to know.
Sir, I would look for the features of CNI toxicity manifesting as in the form of tremors. Then I would like to know the fundus examination changes, except like in the case of a patient is a diabetic or a hypertensive, to know the changes in the retina. Then
Fine.
Because the patient is more vulnerable to infection like meningitis and encephalitis secondary. So I would like to know the status, that is neck stiffness signs, features of meningitis or encephalitis.
No. Meningitis and encephalitis only in critically ill patients. You will not be asked to examine any critically ill patient in the examination.
Okay.
So what is the neurotoxicity of CNIs apart from tremors?
Axonal neuropathies.
Oh, yes.
Uh,
And first, peripheral neuropathy.
Peripheral neuropathy, axonal neuropathies.
Fortunately, these things are rare. Sometimes, the entire body will be tremulous. And all that we have come across, even brachial plexopathy, peripheral neuropathy, and whatnot. There are different forms of neurological manifestations of CNI toxicity, particularly with tacrolimus. But tremors, as you rightly said, that is the most common one.
Okay.
Fine. So the clinical examination, you said the healed marks of the skin lesion. Okay.
Yes, sir. Yes.
So that is what we'll come to that later. So how do you rate the immunological risk status of this pair, mother to son?
Normally, it is seen that at least a half. At least there will be a one haplotype match between the mother and the siblings, sir.
Okay.
But
why is it so? At least
because
one.
usually, sir.
You said at least one haplomatch.
At least will be there. So it actually goes in the inheritance pattern in that 25%.
No, is it? No. I want some clarity on this. Is it at least one haplomatch? Sometimes it means that sometimes you can have two haplomatch as well.
Yes, sir. 25%. There can be at least no haplomatch.
No. Parent to offspring. Parent to offspring, it is one haplomatch.
One haplomatch.
Only one haplomatch.
Okay, sir.
Always, right? Because it's a co-dominant inheritance.
Inheritance.
So one set of the antigens will be from each parent.
Mother, parent.
So that is 25% and 50% and 25%. That is 1:2:1 pattern of matching is among siblings.
Siblings.
Among siblings, there is 25% chance that two haplomatch, 25% chance for no match at all, and 50% chance for one haplomatch.
One haplomatch.
So it is not at least one, it is always one.
Always one.
Okay, unless
Okay, sir.
there are certain theoretical possibilities like highly inbred community and so on. There you can have that, but theoretically it is of very, very meager importance. So
Okay, sir.
practically you have to remember that it is only one haplomatch.
Okay.
So it is immunologically low risk, isn't it?
Low risk.
Yeah. So you would like to give induction immunosuppression for this pair of donor and recipient as well?
As per the KDIGO indication, the recommended is a interleukin-2 receptor antagonist, sir. And in highly sensitized individuals, they prefer the lymphocyte depleting induction therapy, sir.
In high risk, need not always highly sensitized. High risk, any high risk patient, lymphocyte depleting. That's what they say. This is okay. So that's it. So and you are not sure whether induction immunosuppression has been given or not.
In this setting, it was not given.
Yeah. What is your opinion? Does this induction immunosuppression really help in terms of prolonging the graft survival?
It has advantages.
Studies which can vouch on this.
There are studies with the agents like alemtuzumab as well as the basiliximab. Alemtuzumab as well as has been tried in 2 studies, mainly compared with the basiliximab as well as rabbit ATG in a study called as the INTACT study. And also in 3C study also it has been tried against with basiliximab, sir.
No.
So
my question is that all these induction immunosuppressions, have they been successful in improving the graft survival long term?
It actually prevents the short-term probability of reducing the rejection rates, sir, and also it helps in facilitating the dose reduction of the maintenance agents. Apart from that, longer run, it is
exactly uncertain. You're right. I mean, there is still we don't have very robust proof for improving the graft survival in the long term.
Okay.
The maximum, the reduction in the acute rejection rate is certain.
Okay. Yes.
Of these two types of induction immunosuppression, one is the lymphocyte depleting, namely ATG, other
and
one is lymphocyte non-depleting basiliximab. Which one is supposed to favor the T regulatory cell population drugs? Have you heard of Tregs?
Yes, sir. Yes, sir.
What do they do?
Normally, they regulate the immune that suppress the basic immune response, sir.
So it is supposed to induce tolerance.
Tolerance, yes, sir.
Tolerance.
Yes, sir.
T regulatory cells, they induce tolerance, is it?
Tolerance.
Not? So what is there any relationship between these induction agent and promotion of population of Tregs?
There can be down regulation of Treg cells also, sir, when you use
not down regulation. The ATG is supposed to improve the Treg population. So that is one claim. Now, since we are discussing about the long-term benefit of the induction immunosuppression, if at all, the argument has to be this, but the basiliximab does not do that, and T regulatory cell is supposed to go up with use of ATG. Some studies have shown that. So beyond that, both these agents, they have significantly brought down the incidence of acute rejection. But the real benefit in terms of improving the long-term survival of the grafts is yet to be proved.
Proven.
But still, KDIGO guideline is there, so we are just doing that. Fine. You said slow graft function. What do you mean by that?
Slow graft function is normally defined by the occurrence of the fact that the creatinine doesn't fall to the expected lines, normally without the need for a dialysis. So
what is the timeline?
Actually, there has been multiple definitions for slow graft function. It is either expressed as an absolute concentration of the creatinine fall or percentage of the creatinine fall expected between such and such postoperative day. One such definition states that if you have creatinine values more than 3 at postoperative day 5 or more than 2.5 at postoperative day 7 without requirement for a dialysis, then it can be termed as slow graft function, sir.
Okay, fine. So when do you call it as a DGF, delayed graft function?
The requirement of at least a single dialysis during the first week post-transplant can be termed as a delayed graft function.
Exactly. So what are the risk factors for slow graft function? Are
The
there
risk
any
factors,
predictors? Are there any predictors of slow graft function?
degree of HLA mismatch, use of deceased donor transplant with prolonged ischemic times,
Okay.
highly sensitized individuals,
No, highly sensitized is not a risk factor.
older
Anything
age
else?
of recipient,
Prolongation of ischemic times.
older,
Yeah.
higher HLA mismatch, older age of recipient, African Americans and pediatric individuals.
Okay. So most of these points are right. I'm not sure about African Americans. Fine. So what do you think is happening? Why the serum creatinine takes so much time to come down to normal?
There can be a disparity between the whenever the ischemic reperfusion injury and the subsequent injury happens, there can be a disparity in
So
the
we
functions.
surmise it's a kind of a tubular dysfunction or a tubular injury rather than a frank tubular necrosis.
Necrosis.
There are no great biopsy studies and so on. We surmise it is more of tubular dysfunction and mild tubular injury rather than a frank tubular necrosis. Maybe it is a mild tubular necrosis as well.
Yes.
Okay. So what is the kidney biopsy finding? What will be the kidney biopsy finding in a DGF?
It can either show features of maybe tubular cell injury or tubular necrosis, or it might show.
You can simply call it. Then you can simply call it as a post-transplant ATN. Why this special name called DGF?
Because it has been shown that it need not be always a case of ATN. It might also be a harbinger of future rejection. So it might also show.
No, that is the implication of it. Is there any difference in the pathophysiology of a simple ATN, for instance, in ischemic ATN and the ATN occurring in this transplant scenario, immediate post-transplant scenario? What is the name of that injury called?
Ischemic reperfusion injury.
Yeah, so that's it. It is kind of a very unique form of pathophysiology. Otherwise, it is simply ATN.
Okay.
Fine. Let's move on further. Then you said he developed some widespread skin lesions which are vesicular. That's what you said.
Yes, sir.
What is the timeline of occurrence of that?
That is actually after almost close to the end of 2 weeks after transplant, sir.
2 weeks. So what do you think it was?
And according to the site of occurrence, it probably could be a varicella infection, sir. Probably varicella, sir.
Varicella or varicella zoster?
Varicella zoster, sir. Varicella zoster.
Varicella zoster. Why do you say it is varicella zoster?
Because the initial lesions were seen on the typical pattern, that is in the face, that is below the ear, and it gradually started to progress to all of the body, and it showed typically response to a cyclovid treatment also, sir, that particular point of time.
No, varicella zoster. What is the characteristic phenomenon of varicella zoster? How does it occur? It follows what pattern? The occurrence of lesions. Does it not follow a dermatomal pattern?
Yes, sir.
No, according to you, is it a dermatomal pattern of a lesion or it is a scattered widespread lesion?
Scattered widespread lesion, sir.
So still you want to say it is varicella zoster?
Probable, sir.
It's a varicella or varicella zoster?
Varicella.
Varicella. Okay. Fine. So, so is there any difference in the pattern of varicella zoster lesions post-transplant compared to the normal circumstances?
It can. It may occur at any dermatome in a post-transplant setting, sir.
No, it can be multi-dermatomal. Multi-dermatomal.
Oh.
And sometimes rarely it becomes disseminated. So multi-dermatomal. Normally, it in the immunocompetent persons, non-CKD situations and so on. It just usually it is
single T2L1
involving only one dermatome and does not cross the midline and so on.
No.
So did you ask specifically whether these lesions were painful?
Yes, sir. Painful lesions, sir. Painful skin lesions.
So they were painful.
Yes, sir.
Oh, is a varicella lesions? This is the chickenpox lesions. Are they painful?
Normally not, sir. But when it can get secondary infected, it can get painful, sir.
So Did you ask the history of vaccination against varicella?
No, sir.
No, that is important.
Yes,
So in the transplant, the dialysis history, when you elicit actually, you nicely pointed out the dialysis vintage, the access, the number of centers, the blood transfusion history, and any hospitalization for any prolonged hospitalization for any intercurrent illness. Along with that, vaccination history is important.
Okay.
Okay, the vaccination, hepatitis B vaccine, pneumococcal vaccine, varicella vaccine, influenza vaccine, and so on.
Okay, sir.
Now, of course, COVID vaccine. So, what do you know about the varicella vaccine?
Normally, it is a live attenuated vaccine, sir. So, according to the current ISOT recommendations, normally it is not recommended in the post-transplant setting because normally the possibility of number
pre-transplant, yeah,
pre-transplant, and there should be ideally a gap of at least 4 to 6 weeks after the vaccination has been done and the kidney transplant, and the possibility of a vaccine-induced disease is high whenever you give in a post-transplant setting. So that is why it is normally not.
How many doses?
Doses, two doses. Two.
And the second dose should have been mandatorily given at least 4 weeks prior.
4 weeks prior to a transplant.
What do you know about zoster vaccine? Varicella zoster vaccine. Is there a zoster vaccine?
There are 2 vaccinations. One is Shingrix and Engerix vaccine. Sorry, I forgot, sir.
Yeah, there are 2 vaccines. The subtype vaccine, subunit vaccine. So one is a live vaccine, the other one is a inactivated vaccine.
Sorry.
So Shingrix vaccine can be given even post-transplant too.
Okay.
Again, 2 doses. So that is a recent advance in that.
Okay, sir.
So what is the worry about this varicella?
Once varicella occurs
post-transplant period.
So post-transplant setting, being a highly immunocompromised state, it can even progress to produce severe complications of varicella like varicella pneumonia and varicella encephalitis, which can be of high mortality, sir.
Certainly. So what does it reflect, occurrence of varicella about 2 to 3 weeks post-transplant? What does it mean to you?
Probably the intensity of immunosuppression might have been very high.
Right. So here this comes the importance of giving vaccine prior to renal transplantation mandatorily.
Okay.
Unless the patient is very categorical and very confident that the patient has had varicella during childhood, something like that.
Okay.
If you have a doubt, I think you can go for the titers, antibody titers also.
Right.
So that is very important because it poses certain special problems in managing in the post-transplant scenario. One point you have nicely pointed out that there is a potential for degeneration into disseminated form as well as encephalitis, which can be life-threatening. What are the other issues in handling varicella post-transplant? How do you treat it?
Normally, it is treated with injection acyclovir or tab val acyclovir, sir.
Yes, acyclovir. What are the problems with acyclovir?
It itself can actually be nephrotoxic. It can be crystal formation predisposing, sir.
In 2 forms, it can affect the kidney, including graft. One is it can cause acute interstitial nephritis. But more importantly, it can undergo crystallization. And again, it can cause acute graft dysfunction. Does it require dose modification in low GFR?
Yes, sir. It requires dose modification GFR.
So these are the issues, and you have to hydrate, and the patient has to be isolated in case of varicella. And a lot of issues are there. So please make it a point that you vaccinate definitely prior to transplant. So that's it. Then what happened? After that, he developed a pneumonia, the way you are describing pneumonia.
Yes, sir. Yes,
pneumonia, 3rd month or 2nd month post-transplant?
No, sir. Immediately following that 1 week after the onset of skin lesions, he had pneumonia, sir.
So roughly about 4th week.
Yes, sir.
Post-transplant.
4th week. Yes, sir. 4th week.
How do you approach a post-plant setting pneumonia?
Because multiple etiologies can produce pneumonia in the post-transplant setting, especially in the first few months after transplant. So as already mentioned, it can either be a viral or most commonly bacterial cause also for this. And even the protozoal PCP, that is pneumocystis carinii, can also be an important cause for pneumonia in the post-transplant setting, sir. So,
Right. So you need to establish the etiological agent.
yes.
If sputum is not, secretions are not coming up, what do you do?
Bronchoalveolar lavage can be done, sir, and you can actually do for a bronchoscopy.
So can you just tell me how? Can you just tell me how will you confirm diagnosis of PCP?
Normally, in the bronchoalveolar lavage specimen or a bronchoscopic specimen, you can actually show the particular multinucleated cells can be seen, and the ratio of the CD4 to CD8 cells also can be used.
What is the stain you use? No. The stain. What is the stain you use?
Methenamine, Gomori methenamine silver stain.
Gomori.
Methenamine silver stain.
If it is PCP, how do you treat? Please look up. Please note down and look up. If it is PCP, how do you treat?
Prophylaxis
What
we
is the
deal with
timeline? What is the timeline of occurrence of PCP as per Rubin's calendar?
That is usually within 1 to 6 months, sir. That is opportunistic time window period, sir.
Fine. So how do you treat PCP?
Normally, the prophylaxis is mainly using the cotrimoxazole, trimethoprim.
No, I'm asking treatment. Sir. I'm asking treatment.
IV pentamidine can be an option.
Pentamidine straight away.
Cotrimoxazole can be used for the treatment, sir.
No, it'd be very specific about this: the dosing, the duration of treatment,
okay,
the drug of choice, second line, all that.
Okay.
Can it be CMV pneumonia?
CMV can also produce rarely involvement of
again,
the lung.
Which is the preferred timeline of occurrence of CMV post-transplant?
Again, it can be within the 1 to 6 month window period, sir.
1 to 6 months. Okay, fine. So pneumonia in the first month post-transplant is pretty serious. Many times it's very difficult managing, and there is no clear-cut guideline as to how to handle immunosuppression in the face of a severe pneumonia. The one golden principle you have to have in mind is that saving life is more important than saving graft. So many a times you can't have fixed guideline and proceed. You can have some rough guideline, but in a given situation, everyday close monitoring and then taking a decision, taking into multiple factors is important. So the first month post-transplant, the immunosuppression will be pretty high, and if there is a rapid progression of pneumonia, you may have to come down on immunosuppression. Okay. But very interesting point is that most of these viral pneumonias, in the published literature as well as our own personal experience, a reduction in immunosuppression does not always lead on to graft loss. The reason probably most of these viruses themselves are immunosuppressant. Of course, some of them are immunomodulatory and they can precipitate rejection. Most of the infections, for instance, varicella, even if you come down on immunosuppression, varicella pneumonia, if you come down on immunosuppression, most of the times we escape, there's no graft rejection. But the point is that most of the times, the most tricky issue is that when to go back to the original dose. So that is the issue that requires a lot of clinical acumen and expertise. No fixed guideline can really help, and there is no clear-cut guideline in the literature as well.
Okay.
So that's it. So I'm so happy that he come out successfully. He came out of that pneumonia issue, right?
Yes, sir.
So here is one area. Please go back and look up into the types of pneumonia that are possible and the gold standard for confirming diagnosis of each of them, and the prescribed the therapy, the duration and drug. It is all very important. Please note down and kind of revise that. Okay. Then let us move on to the problem of graft dysfunction. When was the first episode of graft dysfunction?
That was actually after the 2 months, sir. 2 months after transplant, sir.
Okay.
almost 2.5 months after transplant.
What is the differential diagnosis for acute graft dysfunction, 3rd month post-transplant, in the order of priority?
It can be the first possibility is always for a rejection, graft rejection. Second possibility, rejection. The second possibility is for the CNA toxicity. Third possibility can be in the form of urological complications like urinary leak or obstruction.
No. 3rd month post-transplant, you don't get urine leak.
Recurrence of the disease can be a possibility.
Okay.
And infection, sir. Graft infection. Infections.
So which infections cause graft dysfunction?
Mainly we know about the CMV and BK virus infection, sir.
CMV, BK
and
virus infection.
Urinary tract infection causing pyelonephritis also can be one possibility, sir.
That's fine. Okay, fine. So how was this graft dysfunction managed? First episode, biopsy was done, is it not?
A biopsy was done and the tacro dose was actually reduced, sir. That was the only intervention that was done after the first.
What does it mean?
Probably the biopsy must have showed, and the levels also must have showed increased levels and suggestive of a CNA toxicity, sir.
So what is the target trough level in your unit, tacrolimus, the first 3 months?
Normally, we'll keep it in the range of 10 to 12, sir. 10 to 12 nanogram per ml, sir.
Okay. Subsequently,
we'll titrate the dose down to that is almost in the 3 to 6 months. We'll down regulate it to slowly around 8 to 10, and from there we'll maintain it in the dose of around 5 to 7, sir.
Actually, in our unit, we try to keep trough level still lower.
Okay.
Our patients don't tolerate 10 to 12 and all that. Intentionally, we don't attempt 12. So some unintentionally, some people may achieve that number, but intentionally, we don't cross 10. Fine. So that is our experience. Anyhow, that's fine. So according to you, probably the biopsy revealed evidence for CNA toxicity, right? So
yes.
Probably what are the features, what are the phenomena in the histopathology that will tell you that it is CNA toxicity?
So the findings can be actually both acute and chronic.
No, here it's acute. In this situation, it's acute. Acute CNA toxicity resulting in acute graft dysfunction. So what are the features?
So it can be visualized. The most common acute phenomenon is a hemodynamic KKA, where there is afferent arterial vasoconstriction. And the other forms of acute manifestations include isometric proximal tubular vacuolization of the proximal tubules can be vacuolized. Then we can also have single myocyte necrosis. Then we can also have the afferent arterial nodular hyalinosis also, sir, in the long run. And in the chronic state, also can have striped interstitial fibrosis also, along with it.
This is acute. Okay. Yes. So predominantly the vascular changes in the tubular epithelial.
And also we can also get TMA, sir.
TMA, yes, exactly. Fine. So how was this acute graft dysfunction managed? There was reduction in the CNA dose. That's all.
A CNA dose was reduced and patient became better and the graft function also recovered, sir.
Fine. So then how many months later, second episode of graft?
Second episode was 1 month after this first episode, sir.
Fine. This time the management was different.
Different, yes, sir.
How was it managed?
It was managed with 6 sessions of plasma exchange, along with probable intravenous immunoglobulin, and initially it was given 3 doses of methylprednisolone, sir.
Fine. So, what are the indications for plasmapheresis in the post-transplant scenario?
The most common setting is in the setting of an antibody-mediated rejection, that is within 1 year of transplant. The second setting where plasma exchange can be used is in the case of a recurrence of FSGS, mainly related to circulating plasma factor. And then the third possibility can be especially managing a TMA post-transplant.
Okay. You think it is ABMR on what grounds? Why can't it be a recurrence of TMA? We don't know the.
Because actually this event was immediately preceded by a reduction in the dose of tacrolimus, which might have precipitated or increased the probability of an underlying rejection, sir.
Fine. So what are the histopathological findings of acute antibody-mediated rejection?
Normally, it manifests in the form of microvascular inflammation in the form of glomerulitis and peritubular capillaritis. It can be involving the vasculature in the form of intimal arteritis also, sir.
Okay.
And then it may
immunofluorescence?
be also manifested in the immunofluorescence by C4D deposition. It may not be, need not be necessary that it may have C4D. 30 to 50% also can have C4D negative cases of with histological evidence of rejection, sir.
What is the explanation for C4D negativity in ABMR?
Number one possibility, it could be that it could be a non-complement fixing antibody. Second possibility, it could be that it could be a technical error.
No, does non-complement fixing DSA cause ABMR at all?
It can cause ABMR, sir. Non-complement fixing antibodies can produce ABMR.
Usually, non-complement fixing antibodies, they don't result in acute antibody-mediated rejection.
Chronic rejection.
The explanation here, absence of C4D staining, is that sometimes some of these DSAs, they prefer a different mode of inflicting injury, a complement independent modes of injury. Like
antibody dependent cell
complement, it can cause
antibody dependent cell cytotoxicity or involving the FC receptors on the innate immune cells.
Exactly.
Or
okay, fine. So what serological tests you would prefer to do when you suspect ABMR?
Normally, cell-free DNA can be. It is a upcoming marker that is donor-derived.
that is more for immunological surveillance.
Okay.
So ABMR, you living related donor, you can jolly well do DSA.
DSA.
So can you just tell me? Please listen to the question. There is ABMR, but your DSA is negative. How do you explain this? You explained C4D negative ABMR.
Yes, sir.
Nicely you explained. But explain to me ABMR, but DSA negative.
It can be an antibody which is not targeted against the HLA molecule. That means it can be a non-HLA antibody, sir. Like antibody to the angiotensin 1 receptor or endothelial cell antibody, etc.
MIC-A?
Sir?
MIC-A, MIC-B.
MICA, that is antibodies to the minor antigens like MICA and MIC-B, H5 antigen, vimentin, glutathione transferase, agrin, perlecan antibodies. Sir.
In spite of it being anti-HLA antibody, can it be negative? Have you heard of prozone phenomenon?
Excess antibodies can actually produce a inhibitory effect, sir. Yes, sir.
Right. So why I want to stress is that, like when you ask for DSA, these facts you should be aware of.
Okay. Okay, sir.
That's fine. Okay. So what is your unit protocol of managing ABMR? Why I'm asking is that there's no definite guideline, definite uniformity in the protocol of management of ABMR.
Yes.
So how do you manage in your unit?
We basically actually doesn't look for the DSA, sir. We basically start treatment after getting the biopsy, or in case of suspicion, we start on plasma exchange. Initially 1.5 plasma volume for the first one, and subsequently 1 plasma volume. Total sessions are 6. Usually we do on an alternate day schedule, and post plasma exchange, we usually give 100 milligram per kilogram IVIG. And at the last day, that is post 6 sessions, if there is a severe microvascular involvement on biopsy, we give rituximab, sir, 375 milligram per meter square, sir. We don't usually check for DSA, sir.
Fine. You give IVIG. How does it help in ABMR?
Normally, it will actually modulate the current circulating antibodies, sir. Current circulating antibodies can be counteracted by the that is IVIG that we give, sir.
That is the only way of action, or any other modes of action?
It can block the FC receptors also.
What is the anti-idiotype effect?
Let's see, sir.
Please learn about it. What are the potential complications of IVIG?
Previously, we were using sucrose containing IVIG, which usually caused what is the osmotic injury, osmotic nephrosis or proximal tubular vacuolization. But now we are actually using mannose containing IVIG, which is actually less devoid of that particular complication. Then it can have infusion related reactions also, sir.
What are the complications of plasmapheresis?
Because the plasma, it contains mainly the clotting factors which are basically removed, it can lead on to a coagulation abnormality. Second, because it contains antibodies which are not pathogenic, which are removed, it can lead on to increased susceptibility for infections also, sir.
Quite good. You said 1.5 volumes. How do you assess one plasma volume?
So normally it can be assessed by the simple equation of 40 ml per kg, or it may be estimated more accurately via one plasma volume is equal to 0.065 into body weight into 1 minus hematocrit, sir.
Good. Fine. So what happened at the end of the so-called treatment session for ABMR? Graft function improved?
The graft function actually came back, sir. 1.5 years discharge with 1.5 creatinine, sir.
Okay. So can you expect the same positive ending or real benefit in terms of improvement in graft function had this ABMR occurred 1 year post-transplant?
Usually the prognosis that we said for a late ABMR is much worse when compared to that of an early ABMR, sir, because
Why
of the
is it so?
pathology difference of a de novo DSA playing more role in a case of late ABMR, sir.
Pathology is not different, but the physiology is different.
Cost at the end.
It's a de novo DSA versus pre-existing DSA.
DSA.
So that's it. So in fact, there are some centers they don't prefer to do plasmapheresis at all.
Yes,
late ABMR.
Late ABMR.
Only thing at the maximum what they do is that optimization of immunosuppression.
Yes.
No rapid down titration of steroids and so on.
Okay.
They try to continue the upper limit of normal range of the trough level. That's what. That's beyond that. There is nothing much can be done about it. Okay, fine. So then the third episode of graft dysfunction happened when?
That is actually 1 month after this particular patient was discharged, sir.
Okay.
Yes.
What are the possible etiology for that graft dysfunction? The third episode.
Probably because of a recent rejection, it could have triggered another episode of rejection. That is one possibility. And in the initial part, we had actually changed over to a drug was actually changed, sir, from tacro to cyclosporin. That was changed. Probably it might have resulted in lower levels of cyclosporin, sir. That could have triggered another episode.
Why tacro was in what situation you would change from tacro to cyclo?
Normally, whenever there is a side effect, TMA, that is one possible side effect of tacrolimus. Second, in case of PTDM, post-transplant diabetes mellitus with the tacrolimus, better glucose profile is seen with cyclosporin. That is second indication. Third, in case of viral infection, sir, because antiviral effect is still somewhat with cyclosporin. So in case of viral infection, we can also change from tacro to cyclosporin.
Good, but we don't use the terminology PTDM anymore. It is NODAT.
Yes, sir.
You are right. So then what happened after the third episode of graft dysfunction?
Actually, he was discharged with a creatinine value, but he doesn't remember the actual value, sir. And he was discharged with almost stable values. That was what he's telling. And within 1 week, he was discharged, sir. But again, what was changed from cyclosporin to tacrolimus once again, sir, after the third episode.
So what do you mean by that?
Probably that could have been probably of the low levels that could have been attained with cyclosporin. The change over to tacrolimus could have been made, sir.
Okay, fine. Then you said about NODAT.
Yes, sir.
Okay, so what do you mean by NODAT?
Defined by new onset of diabetes after transplantation. The previous definition was actually requirement of insulin in the postoperative phase of kidney transplant would mandate the definition of NODAT. Nowadays, actually, the definition has been, or the diagnosis is mainly through a 2-hour OGTT value, sir.
Okay. So, by any chance, the patient should not have been a diabetic pre-transplant. Then you can call it as a new onset diabetes.
Yes, sir.
Is it possible that you can miss diabetes in the pre-transplant period?
Provided the patient, if he was in the impaired fasting glucose tolerance in the IFG or IGT phase, we could have missed that case, sir.
Frank diabetes cannot be missed when the patient is on dialysis.
HbA1c, yes.
So by definition, diabetes meaning increased values. So definitely then what I mean to ask is that despite the blood sugar values being normal,
We can have.
is it possible that the problem at the level of the pancreatic islets might have started in terms of hyperinsulinemia? Is it possible?
Yes, sir.
It's possible.
Yes, sir.
And what happens to the blood sugar profile during renal failure? In renal failure, what happens?
The first point is that the drugs which are normally eliminated by the kidney, that is the anti-hyperglycemic and the insulin, half-life gets prolonged. Number one. Second, the renal contribution to the gluconeogenesis, which is approximately around 30%, also get lowered, sir. So there can be extra half-life of and the drugs as well as lower contribution to the blood glucose profile, leading
Not
to
just
increased
that, not just that, about 1/3 of the insulin metabolized in the kidney.
Okay.
So the bioavailability, the half-life of endogenous insulin also goes up.
Or goes up, sir.
Apparently, your blood sugars can be normal.
Normal, sir.
So apparently,
Yes.
Is it possible that there can be glucose intolerance in renal failure? On the contrary,
Yes, sir. There can be peripheral tissue having resistance to the actions of insulin also, sir.
but that is a very small fraction.
Fraction is.
Previous terminology used to be uremic pseudodiabetes, but
Sure.
nowadays we don't see that at all. What we see is normalization or even hypoglycemia
Yes, sir.
in a non-diabetic. That's what we do see. Fine. But are you not surprised that he has, the way you are describing, he has proliferative diabetic retinopathy within a span
Yeah,
of
it
about
is.
a year, roughly in a year post-transplant?
Yes, sir. Probably he might be having a predisposition to diabetes in the form of IGT or impaired fasting glucose prior, or probably he might have been treated with some like medications which might have triggered the state of hyperglycemia prior, like steroids in, prior to the prior to what when he went for dialysis, sir, transplantation.
No, but
Probably
you
that
have
could-
elicited a history. There was nothing to suggest that.
Yes, sir.
So I think there is genetic vulnerability, predisposition to develop vasculopathy of diabetes. So diabetes is, particularly type 2 diabetes, is very, very complex. Nobody can say that we have understood diabetes. It is not just the occurrence of diabetes, but it also the occurrence of the vascular complications, both micro and macroangiopathy of diabetes. Multiple genes come into play.
Okay.
Okay. And there is a very important history of his father
Having died of
cardiac disease. Probably he also had diabetes.
diet.
You don't know, is it not? Yeah.
Yes, sir.
At what
Yes,
age
sir.
he died? At what age he died?
60, sir. 60.
60 is not a very young age, but no. But at least there is a predisposition for vasculopathy in general. So, but still, I'm really surprised. NODAT in about less than a year, causing a proliferative retinopathy. Is there a chance that his NODAT remained uncontrolled, even though it was only 1 year, 9 months or so? Sometimes, in our follow-up, and we are too much creatinine centric. Sometimes, is it?
Yes, sir.
Is it possible that it remained just uncontrolled?
Probably that
I
could
was
be
under
one
the
of the.
impression that when Tacro was switched over to cyclo, probably it was due to uncontrolled diabetes.
Okay. This
I don't
actually
know.
happened before, sir.
Just asking you. Yeah.
This happened actually before the onset happened, sir. The
Oh,
change
before
was actually made before detecting the diabetes, sir.
So a word of a caution here about is that NODAT presents in multiple formats in different patients. I have come across many years ago when I was in Stanley, a young girl post-transplant, second year, first time NODAT presented with diabetic ketosis. So on the other hand, we do come across NODAT remaining very mild over a period of years and so on. So always, we need to have an index of suspicion whenever there is an acute illness happening, and we have to quickly go back, go through the chart. When was the blood sugar check lost? Sometimes, we are too much creatinine centric. We forget this.
Okay.
Fine. So what are the risk factors for NODAT?
So it can be actually classified into either modifiable, non-modifiable, or potentially modifiable, or it may be classified as a pre-transplantation, transplant, or post-transplant risk factors. So the pre-transplantation risk factors can either be in the form of age, elder age of the patient, a BMI, that is age more than 40, BMI that is more than 30, and ethnicity also has an important role. Apart from that, genetic polymorphisms in an individual, like mutations of HNF4 alpha and mutations of the potassium channel, especially the KAR 6.1 and KCNG 11. And coming out to the transplant scenario, it could be the graft type, that is the disease donor transplantation is more often associated with the chances of NODAT. Then post-transplantation, the risk of the use of drugs, especially steroids, CNI inhibitors and mTOR inhibitors, and the possibility of them having infections like hepatitis C and CMV also increases the risk for post-transplantation diabetes mellitus. And frequent rejection episodes which mandate often the hiking of immunosuppression is also a risk factor for NODAT.
Anything else? Exorbitant weight gain post-transplant. Have you not come across somebody gaining about 20 kilos in 1 year? So what are the implication of sudden massive weight gain on glucose tolerance?
It can promote insulin resistance and thereby can reduce the
rapid, this massive increase in the body weight post-transplant. It's not only a risk factor for NODAT, but also a risk factor for hypertension, post-transplant hypertension. So we have to keep on warning our patients. I used to call it as a vengeful eating. So they've been restricted with regard to the diet for so many years. And with a successful engraftment, appetite is back, and steroid also will induce more of appetite. And beyond this, there is some deeper psychology in that. The way they eat.
Okay.
In a number of times we do come across massive weight gain. So much so that we need to make suitable modifications in the maintenance immunosuppression as well. Okay. The initial dose may prove to be insufficient. Because 40 kilos becoming 60 kilos, it makes some difference, is it not? Yeah. So, and some of them going for central adiposity and obstructive sleep apnea, that adding on to complicated hypertension, resistant hypertension, all that is happening. So we need to focus on post-transplant weight gain as well. Okay. Then you said intraocular injections were given.
Yes, sir.
What is that?
Probably anti-VEGF agent could have been given, sir.
Like?
The proliferative bevacizumab could have been given, sir.
So as a nephrologist, what is your concern about bevacizumab?
It can actually worsen proteinuria, sir, and also it can precipitate TMA, sir.
Mechanism?
Anti-endothelial antibodies can be formed, especially when you give anti-VEGF agents, sir.
Yeah, VEGF is important for your
proliferative.
What is the role of VEGF? What is the role of
neoangiogenesis, sir? In neoangiogenesis, sir.
Yeah, causes that, but in general, VEGF is important for the vascular health, maintaining the endothelial milieu.
Yes.
So, anything which antagonizes this endothelial milieu that can predispose for endothelial dysfunction, and the acute implication, the worst acute implication may be occurrence of TMA. In long term, endothelial dysfunction leading on to vasculopathy, all vascular complications.
Okay.
So that is it. But it is not a contraindication, but we have to be careful about it.
Yes.
Okay. So that's it. And what is the cause for the current graft dysfunction?
Sir?
So again, currently the patient is in graft dysfunction. That's what it.
Yes, sir. Yes, sir. So probably
admitted for evaluation.
Yes, sir.
Is it not?
Yes, sir.
So what do you think is happening?
Probably it could be another episode of rejection, sir, antibody-mediated rejection, or
no,
it could be.
No, I don't suspect another episode of antibody-mediated rejection, because you are maintaining a patient on stiff immunosuppression. Unless there is a non-adherence to that, it wouldn't happen.
Okay.
You have to rule out infections, or it can be a kind of a natural history of evolution of the sequelae of your antibody-mediated rejection. Because even the so-called successful outcome of the first episode of ABMR itself, the lowest creatinine you achieved was 1.5.
Yes, sir. Yes, sir.
So as of now, there is no specific agent that can really answer, that can really treat ABMR.
Okay.
So that is a problem we do have, and that could be probably a chronic sequelae in the sequence of this thing. So would you like to do a graft biopsy again?
After seeing the possibility of CNA toxicity also should be there, sir. So after sending for the tacro levels, and if it is in the normal range, I would like to do a graft biopsy also, sir.
So before that, like any graft dysfunction, how do you
Yep.
proceed? What are the tests you do?
Normally, it can be associated with the blood investigations as well as urine as well as imaging. The blood investigations, especially for seeing the tacro levels and also for the routine analysis to see what is the levels of graft dysfunction. Urine investigation to see whether there is any proteinuria or there is a hematuria. That is, unexplained proteinuria can also be a marker of underlying rejection. New onset hematuria can also be a marker of rejection or disease recurrence per se. And imaging mainly to see for the transplant renal artery stenosis, which also can be a cause for graft dysfunction, sir. And also to rule out obstruction, can be pathologies like obstruction,
So
which
you
can
have
produce
clinical
graft.
examination, urine analysis, and then imaging, ultrasound, tacro levels, and so on.
Yes.
You kept on saying tacro level. What is the methodology by which you do tacro level?
Actually, in our setup, we actually do by the chemiluminescence microparticle immunoassay method, sir. Other methods are also there, which the most accurate one is the high performance liquid chromatography. And also we can use the FPIA method, fluorescent particle immunoassay method, sir.
Fine. So how do you proceed now? Suppose if it is a chronic ABMR in the kidney biopsy,
Yes, sir.
how do you treat? What is this journey from now on?
So if it is a chronic ABMR, there is no point in active treatment. Just to actually enhance the baseline immunosuppression is only what it is required, sir. And with frequent monitoring of the graft function, that is what we can give. Or we can try the certain agents which are there, but it has not been of much use, sir. Newer agents like anti-IL-6 antibodies and all, which are of not much of use, sir.
We don't know that, but initially there have been some promising results,
Yes,
and only time will answer that.
Yes,
some trials are
going
on. As such, we don't have any. Is it possible that he has developed a recurrent IgA nephropathy?
Recurrent IgA nephropathy, the usual, it depends upon the pattern of the involvement of the native kidneys. As we have already seen, progressive rapid disease, they all determine the recurrence of IgA nephropathy. But it has actually been divided by the KDIGO as a clinical recurrence, which is of around 25 to 30%, and histological recurrence around 50%, which is actually determined by the time at which you do the biopsy post-transplant, sir. So, and also the possibility of graft failure is also determined by that. Around 10 years post transplant, the chances of survival, ESRD comes to around 40%, sir.
What is the importance of or the implication of crescents in the native biopsy? What is its impact on the occurrence of post-transplant IgA?
Crescents was actually not included in the initial MEST scoring system, but after 2014 first European conference, it was actually subsequently involved or incorporated to the scoring system. And currently, as it stands,
my question is that does it have any impact at all? Does it have any implication at all in terms of deciding on the adding on to the risk of post-transplant recurrence?
Probably it can produce rapid worsening of the disease, sir. But I'm not sure, sir.
It is a risk factor that has been identified. And again, a new information on that is that always we think of only crescentic IgA nephropathy.
Okay.
The chance for recurrence is high. That's what we have been under the impression.
Yes, sir.
So crescentic IgA nephropathy, by definition, there is a fixed definition. This is not more than 50% involvement should be there and all that, you know. So in a kidney biopsy specimen, if less than 50% of the glomeruli involved and all that, we don't brand it as crescentic glomerulonephritis. But even in such a situation, the mere presence of the crescents itself is a risk factor. So now there is a phenomenon called assessment of the crescent burden in the kidney biopsy.
Okay.
So that requires a specialized technique, some morphometric techniques and so on. So the crescent burden, even a small focal crescent in few glomeruli. So there is a method of assessing the total burden of crescent, and that has an implication on the occurrence of the post-transplant.
Okay.
Okay. But one thing, you know, one important thing all through the history is that the most of this clinical history has happened during the COVID period. So that should have been definitely brought into these things. Now, starting from your pneumonia episode, and patient becoming fatigue, graft dysfunction, all these things everywhere and anywhere, the COVID can be
Okay.
implicated. Okay.
Okay, sir.
So
Okay, sir.
so let us conclude by just one question: the impact of COVID on the renal allograft.
Yes, sir.
Answer that.
It can actually predispose to allograft failure in the form of it may produce de novo collapsing FSGS like lesions, or it may produce vascular involvement like renal artery stenosis or renal vein thrombosis. It also can be, it can also produce interstitial compartment involvement also, sir.
So one, it can cause acute tubular necrosis when there is hypotension, cytokine storm, and hypovolemia, and secondary sepsis, hypoxia, the cytokine storm. All these can cause the tubular injury. That is number one. Number two, collapsing glomerulopathy is supposed to be specific. Okay, what is it called? What is the
Covan, sir. COVID
associated nephropathy. Two, third thing, as you rightly said, there are instances of vascular thrombosis of renal artery, the graft artery, resulting in this thing. Can it cause TMA?
Yes, sir.
Yes, of course.
Yes.
It has been reported. Can rhabdomyolysis happen due to COVID?
Severe. Yes, sir. Yes, sir. It is also.
That also. So all these things, so multiple mechanisms of affliction of graft dysfunction. So that's important. At least insist on the patient, at least now, to go for vaccination.
Okay, sir.
So what do you know about the success of the COVID vaccination in terms of humoral response in kidney transplant recipients? Are there any special challenges?
Being an immunosuppressive state, the obvious serological response usually expected is lower, sir. So
most of the published series, the seroconversion rate, humoral response compared to an immunocompetent population is lesser. So there is an argument suggesting for additional dose.
Multiple doses.
That's it. Thank you. Overall, it was a fair presentation, fairly good. There are some areas of, I know your strengths and strengths were more and weaknesses are less, and concentrate on the points where you require a little more of attention.
Okay.
Overall, I would rate your performance as a good one. Congratulations.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
Sir, actually, the other PG was supposed to present Dr. Nayana, but she had a fever, sore throat day before. So I asked Harikrishnan to present. Yes, sir.
He presented well.
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir. Thank you very much. Thank you, sir. Thank you, sir.
Fine, sir. Now we have a few minutes. Still, it's not over, I think. Somebody will present on this thing, the historical pearl and biostatistics. Who's presenting? Ready? Huh? Dr. Prem Kumar is presenting. It's alpha error and beta error. Why we are including biostatistics in these sessions is that nowadays, biostatistics has become an integral component of the examination. There are some universities where in the theory also, in theory itself, they ask one question in biostatistics. If not in theory, in Viva, certainly there is a question in biostatistics. And also, it has become mandatory that all the postgraduates should have attended a course in research methodology. Otherwise, the results are withheld. Even last week, we conducted one exclusive research methodology course for the sake of higher specialty postgraduates of all the courses in our institution. Please make sure you have a certificate of attendance. Otherwise, the results are withheld. Okay, fine. So much of importance is attached for this statistics and research methodology nowadays. It's good. So may I invite Dr. Prem to present alpha error and beta error.
Now it's showing. Yeah. Okay.
Good afternoon. Today, the topic for discussion is alpha and beta error. Before moving on to the topic major, we'll first we'll see what is the first step in the research methodology is generation of hypothesis. The hypothesis has to be simple, specific, and it has to be pre-specified before the start of the study. And next important thing is the testing of the significance. That before going into the testing of significance, we'll see what is null hypothesis and alternate hypothesis. The null hypothesis is there is no association between the two variables. And the alternate hypothesis is there is an association between the two variables. You cannot straight away prove the alternate hypothesis. For proving the alternate hypothesis, you have to reject the null hypothesis. For example, if an investigator is studying about a particular disease, he cannot study all the people who are at risk. He will select a particular target population and he will formulate his hypothesis and test the hypothesis in that population. And however test he possesses, he cannot absolutely prove the hypothesis. And next, the thing is, he cannot prove the hypothesis because by chance even by a chance he can disprove the null hypothesis, but it is actually an error. There comes the type 1 error, which is also called the alpha error. In this, the investigator rejects the null hypothesis actually, but the null hypothesis is actually true. And it is called error of commission. And usually the significant level is set at 0.05, that is 5%. This alpha thing has to be set before the starting the study. And it means that there is a 5% chance of false positivity in your study. And when the p-value is less than alpha, it means that the p-value falls within the alpha range, and it implies that significant, that is the alternate hypothesis is accepted. And when the p-value is more than alpha, it is not significant. In this case, the p-value it is more than the alpha range, and it means that the value you obtain is more than the chance. It means that it is not significant. And next, moving on to the type 2 error, it is called beta error. It means that in this case, the investigator is not rejecting the null hypothesis when it is false. It is simply called that is false negative, and it is the error of omission. The power
Sorry, there was a power cut here. Sorry for the interruption. May I ask Dr. Prem to resume?
Arpan, screen sharing is
Blue. Shall I continue?
Please continue. Please continue.
Okay, sir. Moving into the type 1 error, it is called alpha error. It is a false positivity. That is, the investigator rejects the null hypothesis that is actually true. That is, there is no association between the two variables, but by chance we assume that there is an association between the two variables. That is false positivity, and it is an error of commission. Usually, the significant level is set as 0.05. That is a 5% chance of accepting the 5% chance of false positivity in your hypothesis. This is acceptable. When the p-value is less than alpha, it is assumed as significant. There is an association between the two variables, and the hypothesis is significant. When the p-value is more than alpha, it is not significant. And moving to the type 2 error, it is called beta error, and it is false negative. It is also called false negativity. And in this, the investigator not rejecting the null hypothesis when it is false. That is, there is an association between the two variables, but the hypothesis by chance states that there is no association between the two variables. It is also error of omission. And for example, if you are if you want to get tested for COVID-19, and actually if you have if you actually have the COVID, and the test says that you does not have COVID, it is type 1 error. And it is if type 2 error, the test says that you does not have COVID, but actually you have a COVID, then it is a type 2 error. And moving on to the power of the study, it is nothing else but the 1 minus beta. That is, the power is inversely related to the beta type 2 error. When the type 2 error decreases, the power of the study increases. For a study, the power of the study has to be 80% or more. To reduce the alpha and beta error, we have to increase the sample size. And in this curve, it is a null hypothesis curve, and in the terminal part of the curve, it is called the critical region, and the shaded part is called the alpha. Actually, by test of significance, it says that null hypothesis rejected, but it actually falls within the null hypothesis curve. This is false positive alpha error. And in the alternate hypothesis curve, the terminal portion, the shaded portion is called the beta. The test of significance says it rejects the alternate hypothesis, but the actual area falls under the curve of alternate hypothesis. This is false negative. And alpha and beta are interchangeable. That is, when decreasing the alpha error, the beta error increases. And by decreasing the beta error, the alpha error increases. For the power of the study has to be more, the beta has to be decreased, and significantly the alpha error also will increase. So for a hypothesis, the acceptable alpha error is 5%, and the acceptable beta error is 0.2. That is, the power of the study has to be 80%. Thank you.
Well presented, Prem. Now I call upon Dr. Vaishnavi to present historical pearls. She is going to talk about none other than Sir Richard Bright.
Good afternoon. I'll be presenting briefly on the life and contributions of Dr. Richard Bright. Richard Bright was born in 1789 in Bristol, England. He is considered to be one of the founding fathers of nephrology. Apart from this, he is also an accomplished artist, naturalist, linguist, geologist, and botanist. He is extensive. Is it sharing? No. He is a physician extraordinaire to the Queen. His extensive travels, especially through Iceland, and his descriptions on the local flora and fauna are still preserved in the museum in London. He was a physician at Guy's Hospital in London, where his contemporaries at the time were Thomas Hodgkin and Dr. Thomas Addison. He has researched extensively on animal chemistry, which is now known as clinical biochemistry. He studied mainly the chemistry of kidney, liver, brain, and blood constituents. His work has contributed and set the stage for correlating this biochemical derangement and tissue pathologies with clinical diseases. This description is found in Bright's writings. One of the ready means of detecting albumin is the application of heat by taking a small quantity of urine in a spoon and holding it over a candle. So more than 170 years ago, his teachings have taught us that for urine of a patient with kidney disease and dropsy curdles when heated, it indicates the presence of albumin in urine. He also differentiated between cardiac and renal dropsy by using this method of detecting proteinuria. He was also one of the first people to recognize that urea retention caused uremia, and the concept of the uremic syndrome was also described by him. He also unified the various factors, that is kidney disease, dropsy, and albuminuria, as belonging to the same clinical condition. This was described as Bright's nephropathy, Bright's nephritis, or Bright's disease. He conducted post-mortem examination of these patients with dropsy, and he found that their kidneys were completely granulated. They had a rough, uneven surface, and internally all traces of this natural organization were lost. So he recognized three basic pathologies by gross examination and autopsy: the pale, large white kidney of nephrotic syndrome, the large red kidney of acute glomerular nephritis, and a small shrunken kidney of chronic glomerular nephritis. This very accurate description of clinical acute glomerular nephritis is found in his work. A child is affected with scarlatina. He finds the secretion of his urine is greatly increased, tinged with blood. He awakes with his face swollen or his ankles puffy. Urine contains large quantities of albumin. The swelling increases. Urine becomes scanty. He suddenly seized with a convulsive fit, becomes blind, eventually succumbs. Apart from this, he also recognized ascites due to various causes. Ascites due to chronic liver disease with portal vein hypertension, ascites of tuberculosis, and ascites of other origins, especially renal diseases. This, he found that when you heat the ascites of patients with tuberculosis, it coagulated, whereas the urine was normal, whereas in patients with renal disease, the urine coagulated when heated. Apart from this, other notable disease descriptions, he has published extensively in the Guy's Hospital reports. He also studied and described this localization of organic brain lesions. He described dysphagia, dysgeusia, and hemianopia, cerebral hemorrhage and abscesses, suppurative meningitis, secondary to ear and sinus infections. He described TB meningitis, SAH with berry aneurysms. He also found that steatorrhea was seen in patients with pancreatic disease. Patients with pancreatic disease also had glucosuria, hydatid cysts, etc. So despite all of his contributions, he's relatively less well known compared to his contemporaries, Dr. Addison and Dr. Hodgkin. Thank you.
Thank you, Dr. Vaishnavi. Well presented on the father of nephrology. How brilliant, what a genial bulk he had been. So he's rightfully recognized as the father of the concept of nephrology field itself. And one more interesting fact is that Guy's Hospital, London used to be the seat of knowledge and wisdom of modern medicine. during his period, when he was in Guy's Hospital, there were two other very prominent the medical scientists. They were also working. All the three were kind of contemporary colleagues. The other two are Hodgkin and Addison. So this trio of Sir, he was knighted, no? Richard Bright is knighted, Sir Richard Bright and Hodgkin and Addison, the famous trio of Guy's Hospital, London. Each one's contribution to modern medicine has been kind of path-breaking, really, no? So that comes to the end of, we come to the end of the historical pulse. I don't know whether it is feasible to go for histopathology. We are struggling. There is some technical glitch. Let me try for a minute. If it is possible, we'll just have a very brief histopathology. Yeah, I think it's opening up. So a middle-aged gentleman, actually, he presented, he was referred to nephrology for raised creatinine and proteinuria. Urine sediment was inactive and kidneys were normalized. He had pancytopenia. Actually, primarily was admitted in general medicine, subsequently to hematology. He also had significant splenomegaly. Splenomegaly with pancytopenia, new onset kidney injury, and subnephrotic proteinuria. With this, biopsy was done. It was quite surprising, exciting too. As you can see here, there are a couple of glomeruli, apparently normal, and there are a lot of cells infiltrating the interstitium. That's what you are seeing. But these are, most of these cells are not the normal components of the interstitium. As you can see here, the whole lot of the cells of the blood lineage, the different lineages of blood are present here. So erythroid precursors, and concentrate here the megakaryocyte, the big one, and a lot of hemosiderin granules in the interstitium, but not in the tubular epithelial cell. Presence of hemosiderin in the tubular epithelial cell denotes something else. Here it was in the interstitium, and there are focal areas of hemorrhage. So it turned out to be kind of extramedullary hematopoiesis. Normally it happens in the liver. Liver is the most preferred site, but the kidney is a very rare, the seat of hematopoiesis. That's what will happen. But how to confirm this? Normally, relatively less initiated or less experienced clinician, nephrologist or pathologist will just pass by saying that some peculiar cells are there in the interstitium. But it requires the true eyes of the pathologist to think about the abnormal morphology of these cells and to go and find out and confirm what they are. There are certain confirmations. How do you confirm the erythroid precursors? By staining with glycophorin here. And for granulocytes, MPO stain, myeloperoxidase stain. And for megakaryocyte, we have to demonstrate a staining with CD61. So look at this megakaryocyte. The presence of megakaryocyte, even if you just spot one megakaryocyte that is so specific, it can never be a normal resident of kidney parenchyma. Even with one megakaryocyte in the interstitium, you can make a diagnosis of extramedullary hematopoiesis. That's what Patrick Walker, the slide was sent to him by Dr. Adila. And that's what he said. They were really excited looking at this, right? The myeloid precursors. So all the three lineages are there. Erythroid precursors, myeloid precursors, as well as the megakaryocyte. So this is the past stain. So again, the megakaryocyte in a bigger view, magnified view in a past stain. So as the name implies, it is such a big cell, So the pearl stain for iron, the iron deposits are in the interstitium. Pearl stain, that picks up iron, is it? Again, another view. And CD61 also was done, and finally it was confirmed to be stain. So I thought we'll share this excitement of getting across coming across extramedullary hematopoiesis in the kidney, presenting as simply proteinuria and kidney dysfunction. I think we come to the end of this session. I hope you all enjoyed. Thank you so much. I thank once again the team Madurai and team Tirunelveli. Special thanks to Professor Ram Subramanian. My best wishes to one and all. Thank you.